হ্যালো আসসালামু আলাইকুম, কেমন আছেন আপনারা সবাই? আজকে today we are going to make a new video regarding the basic surgical skills and anastomosis. So I'm going to make it because I already give you a video of suturing training. So that was basic surgical suturing, but there are other suturing techniques is available in our surgical practice, that is anastomosis of intestinal lumen, anastomosis of the vascular wall, as well as the mucosa. So there are some defects, some complications regarding the vascular anastomosis as well as the gut anastomosis. So let's start. First, introduction. Successful outcomes of the surgery depends on knowledge, skills and judgment. So while this concentrates on technical skills, it is important for the modern surgeon to remember that the non-technical skills such as communication, sympathy, teamwork are a few of the skills required. Okay, so normally any person can dissect, but the surgical dissection and the techniques and skills of plane of surgery is different according to the plan of diseases. So a perfect training or a hand-on training is very necessary for a good surgical skills. And secondly, we used to think of technical skill starting with a knife to skin. So it is a technique, knife to skin. It is also important to realize that a successful outcome of a patient is depend on a surgeon who takes responsibility to make sure that the patient reaches that point with all the factors such as positioning and equipment and considered first. That means a surgeon must take the responsibility of a patient who came for a surgery, because there are many steps what can be hazardous or what can be disastrous, like like there can be anesthetic problems, there can be other problems like positioning problems, like nerve injury, like nerve entrapment, compartment syndrome or pressure source, or other many things that is already previously discussed, and some will be discussed later on. So those all responsibilities must be taken to a surgeon. So it is the sole concern that the patient must be protected from this kind of problems or complications. And now some checklists. So there are some checklists, like the safety of the patient in the operating theater is paramount at all the time and is the key responsibility of the surgeons. So what are the checklists? That is some patient positioning, transfer to and from the operating tables, positioning on the tables, so and the take care of the pressure areas. So pressure areas must be taken care of, like patient at risk from pressure source include those with diabetes, immunodeficiency, obesity and the malnutrition, and those undergoing prolonged procedures. These areas of the body prone to injury are the heels, sacrums and other bony prominences. So what are the common positions of bed sores? So you have to remember these, like heels, sacrum and other bony prominences. Those are the very careful areas that a surgeon must aware of that things, and positioning additional measures taken at the risk, and avoid nerve injuries. So nerve injuries is anesthetized patient can be exposed to neuropraxia, that is nerve injury, and some cases can be permanent and disabling. So like in case of colonic surgeries, hypogastric nerve plexus can be injured in the presacral areas, or the total mesorectal excision. Sometimes mesorectal excision is needed in case of colorectal malignancy, especially rectal malignancy. In that case, bowel bladder habit can be impaired, for which is permanent, or in sometimes In case of pudendal block, in case of any perineal surgery, sometimes anal incontinence or fecal incontinence or urinary incontinence can be happen, which is permanent. So that must be known as well, and the surgeons should lead the theatre team ensuring these areas are protected. Avoid compartment syndrome, considering minimally invasive techniques. So nowadays it is a modern technique, so compartments, so minimally invasive technique is chosen nowadays to minimize the injury, to minimize the hospital stay. So here first, that is skin incision. Skin incision is the first steps of basic surgery. So there are many kind of incisions which depends on many kinds of positionings. So skin incision is given through different kind of knife. That is, it is a knife, so there are different size and different patterns of knives, like 10, 11, 15, 22, 23. So these knives will be attached with the specific BP handles, like handle number 3 will attach in these 10, 11 and 15 will attached with the BP handle number 3, and the 22 and 23 will be attached with the BP handle number 4. Okay, now the 4 factors before skin incision. So there are 4 factors like skin tension lines, anatomical structures, cosmetic factors, and adequate access for the procedures. Why? Skin tension lines. So here you can see pictures of different skin creases. So these are, it is also known as skin crease. So surgeons are trying to make incision along these skin creases or Langer's line. Okay, because if I make the incision along these lines, so there will be limited scar formation, or there will be a good healing. Okay, and there will be less tension. Anatomical structures incision should avoid bony prominences. So incision must be done in the soft tissue, not in the bony prominences. And we must aware of the nerve and vessels underlying the skins, which is very much superficial, like superficial epigastric artery, superficial epigastric nerve plexus. Sometimes they are present in so much prominent or proximal to the area, like femoral artery, like femoral sheath may be present just underlying the structures and soft tissues. So we must aware of making an incision in that area. So there are some vulnerable areas like neck, so like epigastric area. So there are some areas particular like these can be damaged due to recklessly making incisions. So we must avoid those areas. Cosmetic factors, an incision should be made bearing an ultimate cosmetic results. So operation and we must counsel the patient about the cosmetic impairment or if any chances of scar formation or not. And adequate access for the procedure, the incision must be functionally effective for the procedures in hand, because any compromise purely on cosmetic ground may render the operation effective or even dangerous. Now there are number 4 things is we must expose the operative field as I need, because it depends on surgeons to surgeons, but everyone is perfect about their individual skin creases or like exposure. Some needs a limited place, and some surgeons prefer great incisions, because somehow it is very much known that a great surgeons need a great incisions. It is not nowadays is practice, but it was been told many years ago, that is sometimes incisions must be a larger one. Okay, now here you can see some incision lines like upper midline incisions, the lower midline incision, middle midline, rooftop, that is bilateral subcostal incision. This is also called the rooftop incision. Right and left subcostal incisions, right and left paramedian incisions, phalansteal incision below the umbilicus, that is used for cesarean sections. Gridiron incisions also, here the gridiron incisions here. Rutherford mediastinal muscle cut incision, which is L shaped, which is used for proper exposure of the infective appendicitis along with some renal surgeries like nephrectomy. We use rather for Morrison muscle connection, and lens incision, which is given to the good in cosmetic purpose and is usually used in the pediatric surgery along with some appendicectomy. Okay, now you can see the laparoscopic surgery, which is also called the minimally invasive surgery, which is very much popular in modern world nowadays. So there are some benefits of laparoscopic surgery, that is less postoperative pain, better cosmesis, earlier return to normal physiological functions, shorter hospital stay, earlier resumption of normal activities, and principles of safe laparoscopy surgery. So there are some principles which is being followed for any laparoscopic surgery. That is, umbilicus is preferred for primary trocar incisions, and open and semi-open technique is preferred by most surgeons. Open incision insertion away from the umbilicus is safer if there is a midline scar. Secondary trocar should be inserted, removed under the direct vision. So all the trocar should be placed perpendicularly, that is parallel to the abdominal wall. All trocar sites above 5 mm length should undergo closure of the facial layer. That means more than 5 mm if the trocar size was, in that case you have to close layer by layer, not only the superficial layer. Okay, if that is 5 mm or less than 5, then there will be no need of facial repair. It will be closed by superficial skin closures. Okay, so now I am going to show you a place of primary trocar placing. Like this is the umbilicus, so infraumbilical incision was made and the incision was done and the layer by layer was been exposed, and then trocar is inserted. Okay, so this is later on we will make a video about the laparoscopic simulation and the trocar insertion. In that case, in that period I will give you a proper exposure of an introduction of the laparoscopic surgery. Now the suture material, there are now the important is what is suture material. Suture material can be classified as absorbable material, that is thread, needle with thread, which is together called the suture materials. So here the absorbable sutures don't require your doctor to remove them, okay, because it is absorbable. This is because enzymes found in the tissues of our body naturally digest them. Okay, and the non-absorbable sutures will need to be removed by your doctor at later date, or in some cases left permanently. Sometimes non-absorbable suture is used for mask closure or where a tension is usually being produced. So some suture material may need to stay for a long time, or a long time protection, like herniorrhaphy, like mask closure of the abdomen. In that case, non-absorbable suture material like polydiaxone or PDS suture is used. Sometimes proline, that is non-absorbable suture material, polydiaxone, polypropylene, proline monofilament is used. That is also called the non-absorbable suture material. So in previously there are many other non-absorbable was used, like nylon, like silk, naturally non-absorbable suture materials. So second, the suture material can be classified according to the actual structure of the materials. Monofilament sutures consist of single thread, that is one thread, and braided, like rope-like structures, braided. They are united with each other tightly. It has a good tensile strength along with good stability. This allows to structures to more easily pass through tissues. Braided sutures consist of several small thread braided, that is united with each other, and they can lead better security, but at the cost of increased potential for infection, because in the gap of each thread there be tissue infiltration and there be inflammation that may cause infection. In that case, today antibiotic coated braided suture material is available, and maybe that was somehow costly, but it has a good prognosis. So thirdly, sutures can be classified as being made for natural and synthetic materials. However, since all suture material is sterilized, and this condition is not particularly useful. Okay, so they are sterilized, of course. Now there are some wound healing and suture material choices, because wound healing has that already been discussed in previous classes, just in outline. Primary intention, which was a clean wound. And second intention, healthy granulation tissue. then overburdened granulation tissue, infected slurry wound, and a black eschar. So in case of this kind of condition, you have to decide that your wound should be healed in the secondary intention, and the tertiary intention delays closure and skin grafting. In that case, delayed closure and skin grafting will be discussed. Now the suture material desired characteristics. So what are the characteristics has to be needed for any suture material, which is characteristics, that is easy to handle, predictable behavior in tissue, predictable strength and strength, sterile, glides through tissues easily, secure knotting abilities, inexpensive, minimal tissue reaction, non-capillary, non-allergic, non-carcinogenic, non-electrolytic, non-shrinkage. So these are the characteristics it has to be present within a suture materials anyhow. Okay. Now the absorbable suture material. What are the absorbable suture materials? That is guard, that is catgut, which is also called the catgut, the natural monofilament sutures used for repairing internal soft tissues like any blood vessels in the abdomen, any viscera. So we may use for ligation of the vascularity, also the luminous structures you can obstruct with the catgut. And the gut should be used for cardiovascular neurological procedures. The polydiagonal PDS I already discussed, that is it is very tough structures, but tough suture materials which is monofilament, non-absorbable, used for mask closure or abdominal closure. Polycapron or monocryl, this synthetic monofilament used for general use of soft tissue repair, that is it is also called the proline. Okay, proline or polypropylene, it is also monocryl, used for skin closure or superficial skin closure with the taper cut needle. Now the polygalactine or vicryl, this synthetic braided suture is good for repairing hand and facial laceration. It shouldn't be used for cardiovascular neurological procedures. Okay. Now the non-absorbable suture materials, that is nylon, polypropylene, silk and polyester. So these are used which is non-absorbable. Silk is also non-absorbable but naturals. So PDS is delayed absorbable. It is not non-absorbable, it is delayed absorbable. And monocryl, it is also delayed absorbable, which is not used in our country but also used in the Britain and the Australia as well as America. So they use monocryl, but in our country we are not using the monocryl. We use vicryl, PDS, catgut and proline. Okay. So this is the metric systems of suture material thickness. So as you see 1, 1, 0, 2, 2, 3, 3.5, 4, 5, these are means the more thick, it is more thick, more strong, more fatty suture materials, that is a full number, and 50, 40, 30, 20 is more thinner. 50 is used in the vascular repair, so it is more thin, it's like hair like or less than hair diameters. It was so thin, and it was less thinner. So after 2030 is usually for gut repair and 1, 2, 3 for skin repair. So it is more strong, 0, 1, 2, 3, 4 more strong, and 2030 that is more thinner, more finer suture material is usually administered or taken. So as you can see, there are some needle tip of the needle or different size of needle, 1/4 circle, 3/8 circle. So these are the needles we are using. Some are round body, some are taper cuts. So some suture material, tip of the suture material is triangular, sharp. One on the other hand, round bodies means that is the diameter was round and tip was sharper. Okay. So there are some knotting. I already shown you this knotting style, that we have reef knot or square knot, surgeon's knot, that is this knot we used, and we also use this also granny knot or reef knot, and these are the, you can see some stapler. These are the GI stapler, it is also called the GI stapler, and gastrointestinal stapling devices, which is used for side to side anastomosis or the end anastomosis. Okay. And this is the linear cutter. So and this is linear cutter stapling devices. Okay, you can see. So these are the GI staplers which is used for resection anastomosis surgery, which is very much modern. So we don't need to make a hand swing suturing, but it must be learned. It must be learned in your training period, because hand suturing is emergency procedure. Sometimes there will be no availability of this kind of GI staplers. In that case, you have to make the hand swing suturing. Okay. So as you can see, these are the suturing techniques I already given to you. That is subcutaneous suturing, continuous suturing, interrupted suturing, vertical and horizontal mattress. So same distance of vertical and horizontally, you must make the choice for a good repair. Okay, these are the all the pictures of how you can make a perfect suturing along with your needs. Okay, so there are others, anastomosis technique like gut anastomosis, hand sewing procedures. It will be shown you in the videos later on. It is the vascular anastomosis and the suture removal. So you must make your suture material removed where, so it depends according to your organ basis. Like scalp is very much vascular organ, vascularity is very good in that skull area. In that case 7 to 10 days is usually needed, and the face 3 to 5 days. It is more also more vascular in that case 3 to 5 days. Chest and trunk, that is 10 to 14 days, arms 7 to 10 days, legs 10 to 14 days, hands and feet 10 to 14 days, palm and sole feet 14 to 21 days. Because they are so much peripheral part of our organ, there is a less vascular supply, more chances of scar formation or non-healing proportion because of lack of adequate blood supply. Okay, now so you can see there are a video of basic surgical skills that that will be shown in that is shown in my channel. So if you have any interest, you can go through that suturing style. I have tried to show you slowly of each and every knotting in 2 times. In that case, I hope you will like that video also. Now the insertion keeping drain. So now I'm going to discuss about the drain, okay, or the placing drain in the abdomen or any cavity, why it is necessary and why is very important. Because drain are inserted to allow fluid or air that might collect to an operation site in a wound to drain freely to the surface. Okay, so after the operation we place a drain, because after operation there may be chances of rebleeding, chances of inflammatory fluids, some or healing exudates. In that case, that fluid will be accumulated in the peritoneal cavity along with any cavities, may causes invitation of the bacteria or culture media, and also it may be after, in that case there may be an abscess, hematoma or other things, and ultimately sepsis may occur. So to prevent that condition, we use drain. So that fluid may be urine, blood, urine, bile, serum, pus, feces and lymph. So adequate drainage of fluid collections prevents the development of cavities or spaces that may delay wound healing. Okay, so wound healing will be more good if we make a placement on drain. So there are 3 basic principles applying the use of drain. One, drains that utilize the principle of gravity. So you make the drain along the gravity, and semi-open drain that works on the principle of the capillary effect. So your drain will be semi-open. Okay, and the closed drain system is used for suction. If there is an infected wound like a bed sore, if infection of burst appendix or wound dehiscence or any infectious subcutaneous hematoma or abscess, in that case abscess drainage occurs, and there may be a vac dressing or vacuum assisted dressing, which is called the closed drainage system, which will be placed here with a drain. In that case, that will use for suction. So why drain is necessary? Remove any intraperitoneal wound collection of ascites, serum, bile, chyle, pancreatic and intestinal secretions at a signal for the postoperative hemorrhage or anastomotic leakage. You can follow up the patient by checking the drain, or is there any postoperative hemorrhage or anastomotic leakage occurs or not. Then provide a track for a later drainage. So it is a open drain tract for lateral drainage system. In reality, the use of drain usually currently tends to depend on the surgeon's individual preferences, because keeping drain or the duration of keeping drain is individual decisions. So all surgeons are correct by their point of view, but there must be textbook preferences of different disease duration of keeping drain itself. Okay, so there are some disadvantages too of keeping drain for a long time. What are these? So increased intra-abdominal pressure, increased anastomotic insufficiency, increased abdominal pain, and the hospital stay and decreased pulmonary function. So there may be a foreign body sensations, and respiration will be impaired or painful. In that case, pulmonary function will be decreased. Okay, abdominal pain due to some foreign body sensations, anastomotic insufficiency, because sometimes the tip of the drain will make injury to the anastomotic site. That will be disastrous if that is a large gut anastomosis. In that case, it will be anastomotic insufficiency. So chest drain. Now chest drain is an emergency condition. As I am talking about the drain, so discussing of chest drain is important here, because chest drain is indicated for pneumothorax, pleural effusions, and hemothorax, to prevent collection of the fluid and air after thoracotomy. The drain should be connected to an water seal drainage system. This system allows air to leave the pleural cavity, but it cannot be drawn back in by the negative pressure that is created in the intrathoracic cavity. Okay, the system allows air to leave the pleural cavity, but it cannot be drawn back by the negative pressure that created the thoracic cavity. Okay, and between 10 to 20 millimeter of mercury is required to obtain the gentle flow of the bubble from the chest wall. So sometimes pneumothorax, for pneumothorax we must make the negative suction drainage system, that is water seal drainage system. In that case, the air that pressure will be maintained within 10 to 20 millimeter of mercury. Here you can see the chest drain, one end open in the pleural cavity, one end in the underwater. In that case, it is negative pressure is maintained, and the another one, that is that bubble that comes from the pleural cavity will be evaporated through another opening. So it is the chest drain, and it was also called the water seal drainage. Water is used for sealing the pleural space here. Okay, and here you can see T-tube drainage, that is latex T-tube, which is introduced in the bile duct for biliary exploration. If you need any biliary exploration due to chronic cholecystitis, choledocholithiasis, or cholangitis, or in stone diseases or malignancies or reconstruction, any reconstructions, you need to make a placing of T-tube for 10 to 15 days, sometimes 1 month or 2 months. Okay, it is because this area is so much vulnerable for anastomosis, so primary anastomosis is not usually done, so T-tube placement is sometimes necessary. Okay, subcutaneous T-tube placement. So removal of the drain. So drain should be removed as soon as it is no longer required, because if left in, it can predispose to fluid collection, tissue reaction. So drain put in the cover, preoperative bleeding may usually be removed after 24 hours like thyroidectomy. In case of thyroidectomy, 24 hours tube is kept, then after 24 hours the tube must be removed. Okay, so chest drain to drain serous collection can be removed after 5 days like mastectomy. So we need to lay the drain for 5 days in case of mastectomy, or like a massive cut. Okay, there are some serous secretion collection already, collection can be accumulated there, that will be later on may invite abscess or hematoma. Drains put in because of infection should be left until the infection is subsided or the drainage is minimal. Sometimes drains put in the cover colorectal anastomosis should be removed at about 5 to 7 days. However, it should be stressed that in no way does a drain prevent any intestinal leakage. Common bile duct T-tubes should remain in for 10 days. However, once the T-tube cholangiogram has shown that there is free flow of bowel into the duodenum and that there are no stones remained. Okay, Now the T-tube drainage image guided that will be shown you in the videos also. Okay. So electrosurgery, now it is a different branches of surgery where electrical energy is used for surgical field, because development of the first commercial electrochemical devices, that William T. Bovie, who developed the first electrosurgical device in the Harvard University. For many years, shock wave diathermy was proved a most valuable and a versatile aid of the surgical techniques. It is most common use in securing hemostasis by means of coagulation, because we use monopolar or bipolar diathermy to for blood coagulations or hemostasis, which is called the hemostasis. By varying strength or wave from of the current procedures, it can also result in a cutting effect. Both these effects have been used in open surgery as well as laparoscopic surgery or down intraluminal endoscopes, as in transurethral resection of the prostate. Although diathermy is a valuable surgical tools, many accidents have occurred due to the surgeons being unaware of, not fully understanding but the principles of its use. Most accidents are avoidable if the diathermy or the electrocautery is used with care. If we use with care, or if we not use with care, there is some hazard can be happen, like burn, that is electrosurgical burn, diathermy burn, which can be occurred in the intestine or intestinal walls. So that must be remembered. So there are some principles of diathermy, that is intensity of the current, the wave from the current, the electrical property of the tissue through which the current passes, the relative size of the two electrodes. So size, form, the wave, intensity, the frequency. So these are very necessary for maintaining the proper cut and coagulation frequency. So there are some levels which is used for proper cutting or coagulation. There are different type of cutting, like spray coagulation, cut coagulation, diathermy, harmonic scalpel, or other modern methods of ranging presence in the principles of diathermy. So here you can see, look at the pictures here, that is a monopolar and bipolar. Monopolar, that is a circuit which is established from the diathermy unit. One is for handpiece, which is used for active electrode, and another one is which is that is iron plate, okay, or the patient plate, which is attached to the skin, and there is a circuit established, because electricity will go through all over the body. Okay, this is a monopolar system. And another one is a that is bipolar. So there is a two piece here, two electricity started from another. So the current flow will present only in the operative area in between two electrode. Okay, so it is very much good for vessel coagulation, but not good for cutting. Okay, bipolar diathermy is used only for vessel coagulation, not for cutting. Okay, and monopolar is used for both cutting and coagulation in different wavelengths. Now the effect of diathermy, that is coagulation, fulguration, and cutting. So these three systems, three procedures is used in the diathermy for cutting and coagulation. So these are the complications, that is electrocution, or electrocution is very common in case of monopolar diathermy. Explosions, sparks that occurs here can ignite or volatile the inflammable gases and fluid within the theaters, because we all know that proper oxygenation is present in the theater. So if there is any flame, that may causes explosion. And pacemakers, so diathermy must be avoided in case of pacemaker induced patient or any prosthetic induced patient. So because prosthesis and pacemaker will be which is steel built, okay, steel built, in that case that steel built will be electrified and the surrounding structures will be burned out. In that case, pacemakers, if pacemaker is present in a human body, that diathermy must be avoided in that case. Okay, so burn is a complications post, that is diathermy burn is very problematic here. So diathermy, we must aware of the diathermy burn. So faulty applications in different touching problems, and faulty insulations, and diathermy leads, and the cracked insulations, inadvertent activities. So these are the accidental activations, and foot plate, paddle, or accidental contact with the active electrode. In that case, accidentally we can burn in healthy sites, not only through the affected site, but also a healthy site can be affected. And laparoscopy, diathermy, the wrong structures because of lack of clarity of vision or miscon. Because in case of laparoscopic surgery, we use a diathermy, but it is very much cautious where we are using that energy. So wrong structures because of lack of clarity of visions or the misidentification must be prohibited. Faulty insulations, inadvertent activities, same things, but you must identify where you are putting the energy sources in the viscera, because if that is wrong, there will be irreversible damage, like a bile duct, like right and left hepatic duct, or any gut. If you make the diathermy, that will be perforated or dissected. In that case, there will be irreversible burn injury. Okay, now the modern electrosurgical devices that is used nowadays, which is harmonic scalpel devices or the thunder beats. Okay, you can see there is two devices which is used for simultaneously cutting and coagulation is done in every second, because here it is not only it is basically a monopolar system, but used for both cutting and coagulation. As we know, previously normal bipolar procedures is used only for vessel sealing or vessel coagulation, but in this process or the machines can done cutting and coagulation in same time. In that case, they are using sound wave, like you can see the 20,000 to 50,000 hertz ranges of sound wave is used for cutting and coagulation in the same time or simultaneously. So in case of Olympus company, they provide the thunder beats, both single devices. Okay, simultaneously ultrasonic vibration and bipolar diathermy in the single time. The device is able to seal and divide arteries in vein in 7 mm in diameter. There is also seal only, mood activated. There are also seal only. There may be another options, you can activate that, and which activate bipolar diathermy only. So simultaneously or single by single you can activate that things. A harmonic scalpels is also the instrument ultrasound technology, and cut tissue is simultaneously sealing them. It is same things, but two different companies. One is for Storch or Johnson & Johnson Storch, another one is Olympus, that is Thunderbit. Okay, I hope I can understood the basic things about the electrosurgery. Okay, that is all about our presentations, because as a basic surgical techniques, which is a course that is established nowadays in our country, all over the country. So maybe in some few days or few months or years, I am going to start basic surgical training as well as in my operating room. In that case, I will make the most training by practical, not only for lectures. It is simple lectures from the Bellies and Loves from the Royal College of Surgeons. So they are establishing a basic surgical courses, and through I have taken some lectures from there and try to make a video like this. So I hope you like my channels and like my videos. If you like that, so keep subscribe and like my channels and like my videos, and share the videos with your Facebook, YouTube, and as well as the Instagram also. Thank you very much for patience hearing. Stay home, stay safe. It is a global pandemic, so I hope you will continue with my lectures. Thank you very much. Thank you.